Welcome back, everyone. This is the last lecture of Pharmacology Explained series based on Toronto Notes 2025. We continue from the previous page and start with therapeutic index. The therapeutic index. Let's begin with the figures at the top of the page. The therapeutic index is a measure of a drug's margin of safety. It compares the dose that produces toxicity with the dose that produces desired therapeutic effect. The formula is therapeutic index equals to TD50 and ED50, or toxic dose 50 and effective dose 50. ED50 is the median effective dose, the dose that produces the desired effect in 50% of the population. TD50 is the median toxic dose, the dose that produces toxicity in 50% of the population. The greater the distance between ED and TD50, the safer the drug. In this graph, the left curve represents therapeutic efficacy. The right curve represents toxicity. And the wider the separation between these curves, the larger the therapeutic index and the safer medication. Now let's look at the second graph comparing drug A and drug B. Drug A has a narrow therapeutic index. The dose required to achieve maximum therapeutic benefit overlaps with the dose that already produced toxicity in many patients. At full efficacy, approximately 50% of patients experience toxic effects. Drug B has a much wider therapeutic index. At its fully effective dose, toxicity occurs in only about 10% of patients, making drug B much safer. Clinical pearl. Drugs with a narrow therapeutic index require careful dosing and close monitoring because even a small dosage changes may result in toxicity. Examples include digoxin, lithium, warfarin, phenytoin, and aminoglycosides. Therapeutic drugs monitoring, or TDM. Now let's discuss therapeutic drug monitoring. Therapeutic drug monitoring is the measurement of serum drug concentrations to optimize drug therapy. Its goals include achieving therapeutic drug levels, avoiding toxicity, improving efficacy, guiding dose adjustments, and assessing medication adherence. Drug levels are usually measured after the drug has reached a steady state, which occurs approximately 4 to 5 half-lives. When is TDM indicated? Therapeutic drug monitoring is especially useful when drugs have a low therapeutic index, unpredictable dose-response relationships, large variability in pharmacokinetics between patients, and serious consequences if drug levels become too low or too high. TDM is also particularly valuable in patients with renal insufficiency, hepatic failure, dialysis, hypoalbuminemia, other complex clinical conditions affecting drug clearance. Nomograms are often used to guide dosing for drugs with a narrow therapeutic window. Drugs commonly monitored. Examples include vancomycin, aminoglycosides such as gentamicin and tobramycin, digoxin, phenytoin and other anticonvulsants, warfarin, and lithium. Remember these drugs because they are frequently tested in clinical practice and examinations. Adverse drug reactions, ADRs. Now let's move to adverse drug reactions. First, it is important to distinguish between adverse drug events, or ADEs, and adverse drug reactions, ADRs. An adverse drug event is any harmful event occurring while a patient is taking medication, regardless of whether the medication is actually caused it. An adverse drug reaction is a harmful response that occurs when a drug is used appropriately at normal therapeutic doses. In other words, ADE does not require proof that the drug caused the event. ADR implies a causal relationship with the medication. Classification of adverse drug reactions, type A to E. Understanding the classification of ADRs is very important. Type A, augmented. A stands for augmented. These reactions are dose-related, predictable, and an extension of the drug's normal pharmacological effect. They account for over 80% of all adverse drug reactions. Examples: a patient taking a beta blocker develops bradycardia because excessive beta blockade slows the heart. Management usually involves reducing the dose. Type B, bizarre. B stands for bizarre. These reactions are not dose-related, unpredictable, and often immune-mediated or genetically determined. Examples include penicillin anaphylaxis, drug hypersensitivity, malignant hyperthermia, and idiosyncratic reactions. Although uncommon, they are often severe. Type C, chronic. C stands for chronic. These reactions are related to cumulative doses and long-term therapy. Examples include atypical femoral fracture from prolonged bisphosphonate use, retinal toxicity from long-term hydroxychloroquine therapy. Type D, delayed. It stands for delayed. These reactions occur sometimes after drug exposure, sometimes even after treatment has ended. Examples include cardiotoxicity developing after treatment with doxorubicin. These reactions may or may not be dose-related. Type E, end of use. E stands for end of use. These are withdrawal reactions occurring after discontinuation of medicine. Examples include stopping chronic opiate therapy leading to opiate withdrawal syndrome. Tips to reduce drug-related adverse events in older adults. Older adults are particularly vulnerable because aging alters drug metabolism and elimination. Several practical strategies can reduce adverse events. Regular review, long-term predictions, and adjust doses based on age, kidney function, and liver function. Reassess medications started during hospitalization and discontinue those no longer needed. Minimize polypharmacy by describing unnecessary medications. Before increasing dose, verify that poor response is not simply due to poor medication adherence. When possible, select medications with a wide therapeutic index and reconcile medication less regularly to prevent duplicate therapies and dosing errors. Antibiotic allergies and cross-reactivity. Finally, let's discuss antibiotic allergies. Cross-reactivity is an important clinical consideration. For patients with penicillin allergy, cross-reactivity with the cephalosporins is generally less than 2%. However, in patients with a history of a true anaphylaxis, the risk may approach 40%, especially when the drugs share similar side chains. Cross-reactivity between penicillins and carbapenems is less than 1%, making carbapenems relatively safe in many cases after careful assessment. Another important concept involves sulfa allergy. The term sulfa allergy is frequently misunderstood. Current evidence suggests minimal cross-activity between sulfonamide antibiotics, suggest as trimethoprim, sulfamethoxazole, and non-antibiotic sulfonamide-containing drugs, including loop diuretics such as furosemide, thiazide diuretics such as hydrochlorothiazide, carbonic anhydrous inhibitors such as acetazolamide, sulfonyl urease such as glipizide, and certain protease inhibitors. Therefore, patients allergic to sulfonamide antibiotics can often safely receive these non-antibiotic medications after appropriate clinical evaluation. To summarize this page, the therapeutic index TD50 and ED50 measures a drug safety margin. A higher TI indicates a safe drug. Drugs with a narrow therapeutic index require careful dosing and therapeutic drug monitoring. Therapeutic drug monitoring helps optimize efficacy while preventing toxicity and is performed after steady state is reached. Common drugs requiring TDM includes vancomycin, aminoglycosides, digoxin, phenytoin, warfarin, and lithium. Type A ADRs are dose-related and account for the majority of adverse reactions. Older adults are at high risk for drug toxicity because of physiological changes and polypharmacy. Most reported penicillin allergies do not absolutely prevent the use of cephalosporins or carbapenems, but careful assessment of allergy history is essential. This concludes our lecture on therapeutic index, therapeutic drug monitoring, and adverse drug reactions. Three fundamental concepts that guide safe and effective medication use in clinical practice. Now let's move on to the next page. Let's begin with the approach to suspected adverse drug reactions located at the left of the page. At the top left of the page. Whenever a patient develops unexpected symptoms after starting a medication, the first step is obtaining a thorough history and physical examination. Look for clinical signs such as skin rash, fever, hepatitis, anaphylaxis, and any other symptoms that appeared after the drug exposure. An accurate timeline is extremely important. Ask, when was the medication started? When did the symptoms begin? Did symptoms improve after stopping the drug? This is called the challenge. Did the symptoms return if the medication was restarted? This is called re-challenge, although this is only performed when it is safe and appropriate. A complete medication history should include every product that the patient is using, not only the prescription drugs, but also over-the-counter medications, herbal and natural health products, vitamins and supplements, creams, eye and ear drops, inhalers, and nasal sprays. For each medication, document dose, frequency, route of administration, and duration of use. Next, determine whether the patient's symptoms are truly caused by the medication or whether they are simply part of the underlying disease. Management of serious ADRs. For severe adverse drug reactions, immediately discontinue the suspected medication, provide supportive care, and treat symptoms appropriately. Some immune-mediated reactions require treatments such as corticosteroids and immunosuppressive therapy. Resources for ADR evaluation. The page also emphasizes the importance of consulting reliable resources. These include recent medical literature, Health Canada, the US FDA, pharmaceutical manufacturers, poison control centers, mother to baby when evaluating medication safety during pregnancy or breastfeeding. Reporting adverse drug reactions. Healthcare providers should report suspected ADRs that are unexpected, serious, associated with the newly marketed drugs. Reporting helps identify a rare adverse effect that may not have been recognized during clinical trials. The page also mentions the Canadian Adverse Drug Reaction Monitoring Program, which allows online reporting. Variability in drug response. Now, let's move to the next section titled Variability in Drug Response. One of the most important principles in pharmacology is that patients do not all respond to medications the same way. Clinical trials determine average doses, but individual patients often require adjustments. Many factors contribute to variability. 1. Medication adherence. The simplest explanation is that the patient may not be taking the medication correctly. Poor adherence is a common cause of treatment failure. Number 2, drug absorption. Several gastrointestinal conditions can alter absorptions, including vomiting, diarrhea, steatorrhea. Drug absorption is also influenced by the first pass effect, which may increase or decrease because of enzyme induction, enzyme inhibition, and liver disease. Number 3, pharmacokinetic and pharmacodynamic drug interactions. Other medications may interfere with absorption. For example, calcium carbonate can bind medications such as iron, levothyroxine, fluoroquinolone antibiotics. This complex formation reduces absorption and decreases therapeutic effectiveness. Drug distribution. Drug distribution varies depending on body fat percentage, blood-brain barrier integrity, age, neonatal physiology, and liver dysfunction. These factors influence where medications travel throughout the body. Number 5, biotransformation and elimination. Metabolism differs between individuals because of genetic polymorphisms, enzyme deficiencies, kidney disease, and liver disease. Examples include CYP450 polymorphisms and acetylcholinesterase deficiencies. These genetic differences may produce either toxicity or reduced drug effectiveness. Number 6, pharmacodynamic variability. Finally, patients may respond differently even when drug concentrations are identical. Reasons include genetic receptor differences, immune-mediated drug reactions, disease states, drug tolerance, and cross-tolerance. This represents pharmacodynamic variability. Drug interactions. Drug interactions occur whenever one medication, food, or natural health product changes the effect of another medication. Examples include herbal products such as St. John's wort and foods like grapefruit juice. Drug interactions are divided into pharmacokinetic and pharmacodynamic interactions. Pharmacokinetic interactions. Pharmacokinetic interactions after the drug concentration within the body. They may affect 4 stages. Absorption. Examples include changes in gastric pH, gastric emptying, intestinal motility, and drug transporters. Distribution. Interactions may alter blood flow, plasma protein binding, tissue barriers, and drug transport proteins. Metabolism. Some drugs inhibit liver enzyme, increasing drug concentrations. Other induce liver enzymes, lowering drug concentration. Excretion. Interactions may alter renal elimination and hepatic elimination. These changes how quickly medications leave the body. Pharmacodynamics interactions. Pharmacodynamics interactions occur when drugs influence each other's effect without changing blood concentrations. They may be additive, synergistic, and antagonistic. Understanding these interactions help prevent therapeutic failure and drug toxicity. Examples of clinically relevant drug interactions at the right side of the table. Now let's review the table title, Examples of Clinically Relevant Drugs Interactions. Several classic interactions are highlighted. Warfarin plus antibiotics. Antibiotics such as ciprofloxacin, erythromycin, metronidazole, and trimethoprim sulfamethoxazole increases warfarin anticoagulant effect, raising the risk of bleeding through multiple pharmacokinetic and pharmacodynamic mechanisms. Warfarin plus acetaminophen. Chronic high-dose acetaminophen may increase the INR and enhance warfarin's anticoagulant effect. Oral contraceptives plus rifampin. Rifampin reduces CYP3A4 enzyme, increasing hormone metabolism and reducing contraceptive effectiveness. Sildenafil plus nitrates. Both drugs increase cyclic GMP, producing profound vasodilation that can lead to severe hypotension. This combination is contraindicated. SSRIs plus St. John's wort. Combining these serotonergic agents increase the risk of serotonin syndrome. SSRIs plus selagelin or non-selective MAO inhibitors. These combinations also markedly increase serotonin level and may produce life-threatening serotonin syndrome. Statins plus CYP3A4 inhibitors. Certain statins combined with drugs such as clarithromycin, erythromycin, itraconazole, gimfebrozil, or ritonavir increase the statin concentrations and may lead to rhabdomyolysis. Trimethoprim sulfamethoxazole plus ACE inhibitors, ARBs, or spironolactons. This combination significantly increases the risk of hyperkalemia, especially in elderly patients and those with kidney disease. To summarize this page, always evaluate adverse drug reactions using careful history medication review, de-challenge, and when appropriate, re-challenge. Recognize that patient responses vary because of differences in absorption, distribution, metabolism, elimination, genetics, and pharmacodynamics. Drug interactions can be pharmacokinetic or pharmacodynamic and may substantially alter drug safety or effectiveness. Familiarity with the common high-risk drug interactions, especially involving warfarin, rifampin, nitrates, SSRIs, statins, and potassium-elevating medications is essential for safe prescribing. Now let's move on to the next page. The autonomic nervous system, ANS. The ANS is responsible for regulating involuntary body functions such as heart rate, blood pressure, respiration, digestion, glandular secretion, and smooth muscle activity. It constantly maintains homeostasis by balancing the actions of its two major divisions, the sympathetic and the parasympathetic nervous system. Let's begin with figure 7, which illustrates the organization of the peripheral nervous system. The peripheral nervous system divides into the somatic nervous system, which controls voluntary movement of the skeletal muscles, and the autonomic nervous system, ANS, which controls involuntary organ function. The autonomic nervous system further divides into sympathetic nervous system, CNS, SNS, the fight or flight system, and parasympathetic nervous system, the PNS, the rest and digest system. Most organs receive dual innervation from both systems. These two divisions usually produce opposite physiological effects, allowing fine control of organ function. Major neurotransmitters of the ANS. The two principal neurotransmitters are acetylcholine and norepinephrine. Acetylcholine. Acetylcholine acts on cholinergic receptors, which include nicotinic receptors and muscarinic receptors. The action of acetylcholine is rapidly terminated by acetylcholinesterase within the synaptic cleft and pseudocholinesterase in plasma. Because acetylcholine is broken down quickly, cholinergic responses are usually brief. Acetylcholinesterase inhibits drugs such as pyridostigmine, donepezil, galantamine, rivastigmine. Inhibit acetylcholinesterase, increasing acetylcholine concentration. Clinically, these drugs are used to treat myasthenia gravis and Alzheimer's disease. Norepinephrine. Norepinephrine primarily stimulates adrenergic receptors including beta 1, beta 2, alpha 1, and alpha 2. Its action ends by reuptake into the presynaptic neurons, diffusion away from the synapse, metabolism by monoamine oxidase, and metabolism by catechol O methyltransferase. Parasympathetic nervous system. The parasympathetic nervous system promotes conservation of energy and normal body maintenance. Interestingly, several structures receive no parasympathetic innervations, including blood vessel, sweat glands, splenic capsule, and adrenal medulla. Origin of parasympathetic fibers. Preganglionic neurons originate from the cranial nerves 3, 7, 9, and 10, and sacral spinal cord level S2 to S4. This arrangement is known as the craniosacral outflow. These long preganglionic fibers synapse in ganglia located very close to or within the target organ through nicotinic receptors. Postganglionic neurons then release acetylcholine onto muscarinic receptors located on effector organs. Important receptor subtypes include M1 receptor, primarily located in the central nervous system, and M2 receptors found in the cardiac muscles, smooth muscles, and glandular tissue. Sympathetic nervous system. The sympathetic nervous system prepares the body for stressful situations by increasing oxygen delivery and energy availability. Preganglionic neurons originate from the spinal cord at the T1 through L3 or L2, known as the thoracolumbar outflow. These fibers synapse via nicotinic receptors within either paravertebral ganglia, forming the synaptic chain adjacent to the vertebral column, and prevertebral ganglia such as celiac and mesenteric ganglia located within the abdomen. Post ganglionic neurons then release norepinephrine onto adrenergic receptors. Major receptor locations include beta 1 receptors in the heart, beta 2 receptors in the bronchial and gastrointestinal smooth muscles, alpha 1 receptors in vascular smooth muscles, alpha 2 receptors in vascular smooth muscles, and M3 muscarinic receptors in sweat glands, which are an important exception because sympathetic stimulation here uses acetylcholine rather than norepinephrine. Figure 8. Autonomic nervous system efferent tracts. Now let's examine Figure 8. Both sympathetic and parasympathetic pathways begin with the preganglionic neurons that release acetylcholine onto nicotinic receptors located within autonomic ganglion. The difference occurs after the ganglion. In the synaptic pathway, postganglionic neurons usually release norepinephrine, which acts on adrenergic receptors. In the parasympathetic pathway, postganglionic neurons release acetylcholine, which binds to muscarinic receptors on target organs. This shared preganglionic cholinergic transmission, but different postganglionic neurotransmitters, is a key concept in autonomic pharmacology. Table 3. Direct effects of autonomic innervation and cardiorespiratory system. Let's now review Table 3, which summarizes the direct effects of sympathetic and parasympathetic stimulation on the heart, blood vessels, and lungs. Heart. Under sympathetic stimulation, beta 1 receptors in the sinoatrial node increases the heart rate. Beta 1 receptors in the atrioventricular node increases conduction velocity. Beta 1 receptors in the atria increase contractility. And beta 1 receptors in the ventricle increases contractility. Parasympathetic stimulation through muscarinic receptors produces the opposite effects. Decreases heart rate, decreased AV nodal conduction, and reduced atrial contractility. Overall, sympathetic activity increases cardiac output, whereas parasympathetic activity slows the heart. Blood vessel. Sympathetic effects vary depending on receptor subtypes. Alpha 1 receptors produce vasoconstriction in skin and splanchnic vessels. Beta 2 receptors produce vasodilation, particularly in vessels supplying skeletal muscles. And coronary circulation may exhibit both alpha-mediated constriction and beta-mediated dilation depending on the physiological condition. Parasympathetic stimulation generally promotes vasodilation where parasympathetic innervation is present. Lungs. Sympathetic stimulation activates beta 2 receptors, causing bronchodilation through relaxation of bronchial smooth muscles and minimal stimulation of bronchial gland secretion. Parasympathetic stimulation through muscarinic receptors causes bronchoconstriction and increased bronchial gland secretion. These opposing actions explain why beta 2 agonists such as salbutamol are effective bronchodilators in asthma, while muscarinic antagonists such as ipratropium reduces bronchial constriction. To summarize this page, the autonomic nervous system consists of sympathetic and parasympathetic division, which usually exert opposing physiological effects. Acetylcholine is the neurotransmitter released by the preganglionic autonomic nervous. Parasympathetic postganglionic neurons release acetylcholine onto muscarinic receptors. Sympathetic postganglionic neurons primarily release norepinephrine onto adrenergic receptors. Figure 7 demonstrates the organization of peripheral and autonomous nervous system. Figure 8 illustrates the neurotransmitters and receptors use the autonomic different pathways. Table 3 summarizes the receptor-mediated effects of the sympathetic and parasympathetic stimulation on the heart, blood vessel, and lungs, providing an essential framework for understanding autonomic pharmacology and the mechanism of many clinical important drugs. Now let's move on to the next page, opioid therapy and chronic non-cancer pain. Chronic non-cancer pain includes long-term pain conditions such as osteoarthritis, chronic low back pain, neuropathic pain, and fibromyalgia. While opioids can provide pain relief, they carry significant risk including tolerance, dependence, opioid use disorder, overdose, and death. Therefore, current guidelines recommend careful and limited use. General management principles. The first recommendation is that non-opioid pharmacological therapy and non-pharmacologic treatments should be optimized before considering opioids. Non-opioid medications may include acetaminophen, NSAIDs, antidepressants such as duloxetine, anticonvulsants such as gabapentin or pregabalin. Non-pharmacologic therapies include exercise program, physiotherapy, weight reduction, cognitive behavioral therapy, and psychological support. These approaches often provide long-term improvement with fewer risks than opioid therapy. The second principle is to avoid high opioid doses whenever possible. If opioids are necessary, start with the lowest effective dose, increase doses slowly, and regularly reassess benefits versus harms. If discontinuation becomes appropriate, taper opioids gradually using a collaborative approach with the patient. Abrupt discontinuation should be avoided because it may precipitate withdrawal symptoms and worsen pain. The third recommendation concerns opioid dosage. Patients beginning opioid therapy should generally receive less than 90 morphine milligram equivalents, or MME per day. Ideally, less than 50 MME per day, particularly when initiating therapy. Lower doses reduces the risk of overdose while maintaining pain control. For patients already receiving 90 MME per day or more, guidelines recommend encouraging a slow, patient-centered taper toward the lowest effective dose and, if possible, complete discontinuation. The tapering schedule should always be individualized according to the duration of opioid therapy, patient's preference, withdrawal symptoms, functional status, and pain control. Patients who experience major difficulties during opioid tapering may benefit from a formal multidisciplinary pain management program involving physician, pharmacists, psychologists, physiotherapists, and pain specialists. This term-based approach addresses both physical and psychological aspects of chronic pain. Evidence summary. Does opioid tapering increase pain? The evidence summary shown on the right side of the page answers an important clinical question. Does tapering opioids make chronic pain worse? A systemic review analyzed 20 studies involving more than 2,100 patients. The findings were encouraging. In approximately 80% of studies, pain actually improved after opioid tapering. Around 15% of studies reported no significant change in pain. Very few studies demonstrated worsening pain. Conclusion: current evidence suggests that carefully supervised opiate tapering does not usually increase pain and may actually improve pain, function, and quality of life in many patients. However, because most available studies are of moderate quality, additional controlled research is still needed. Table 4. Common drug endings. Now let's review Table 4, which lists common medication suffixes. Recognizing these endings helps identify drug classes quickly during clinical practice and examinations. AFL represents PDE5 inhibitors. Examples include sildenafil. These drugs are commonly used for erectile dysfunction and pulmonary hypertension. AIN represents inhaled general anesthetics. Examples include halothane. These agents are used to induce and maintain general anesthesia. Azepam represents benzodiazepines. Examples include lorazepam. These medications provide anxiolytic, sedative, anticonvulsant, and muscle relaxant effects. Azole represents antifungal medications, for example, ketoconazole. Remember that there are exceptions, so not every azole drug is an antifungal. Cane represents local anesthetic. Examples include lidocaine. These drugs block sodium channels and prevent nerve conduction. MAB represents monoclonal antibodies. Examples include adalimumab. These biologic medications target specific immune molecules and are widely used in autoimmune diseases and oncology. NIB represents small molecule kinase inhibitors. Examples include imatinib. These medications inhibit intracellular signaling pathway involved in cancer cell growth. OLO represents beta blockers. Example includes propranolol. They decrease heart rate and blood pressure and are commonly used for hypertension, ischemic heart disease, heart failure, and arrhythmias. Prazole represents proton pump inhibitors. Example includes omeprazole. These drugs suppress gastric acid secretion and are used to treat GERD and peptic ulcer disease. Prel decreases ACE inhibitors. Examples includes captopril. ACE inhibitors lower blood pressure and provide cardiovascular and renal protection. Sartan represents angiotensin receptor blockers, or ARBs. Examples include candesartan. These medications are commonly used when ACE inhibitors are not tolerated. Statin represents HMG-CoA reductase inhibitors. Examples include atorvastatin. Statins reduce LDL cholesterol and lower cardiovascular risk. Terol represents beta-2 antagonists. Examples include albuterol. These drugs produce bronchodilation and are widely used in asthma and COPD. Tidine represents H2 receptor antagonists. Examples include cimetidine. These medications reduce gastric acid secretion, although proton pump inhibitors are now used more frequently. Tropin represents pituitary gland hormones. Examples include somatotropin. Somatotropin is a recombinant human growth hormone. Vir represents antiviral medications. Examples include acyclovir. Many antiviral drugs share these effects. Zosine represents alpha-1 antagonist. Examples include prazosin. These medications are used for hypertension, benign prostatic hyperplasia, and sometimes post-traumatic stress disorder-related nightmares. Important note: The page emphasizes that these drug endings are helpful recognition tools but are not absolute rules. Exceptions exist, and clinicians should always consider the complete drug name and clinical context. Dangers, abbreviations, symbols, and dose designations. The final section introduces an important patient safety concept. Medication error frequently occur because certain abbreviations, symbols, or dose expressions are easily misread. The page states that the dangerous abbreviations listed in Table 5 should never be used when communicating medication orders because they are associated with harmful medication errors. Examples commonly include writing U instead of unit, using IU instead of international units, trailing zeros such as 5.0 milligram, missing leading zeros such as 0.05 milligrams, 0.5 milligrams, sorry. Misinterpreted abbreviations for daily or every other day. Using standardized medication terminology improves communication and significantly enhances patient safety. To summarize this page, optimize non-opioid and non-pharmacologic therapies before prescribing opioids for the chronic non-cancer pains. Use the lowest effective opioid dose, ideally less than 50 mme per day, and avoid doses exceeding 90 mme per day whenever possible. Slow, collaborative opioid tapering generally does not worsen pain and may improve patients' outcome. Learn the common drugs effects in Table 4 as they provide valuable clues about a medication's pharmacologic class and mechanism of action. Dangerous abbreviations and unclear dose designations contribute to medication errors and should be avoided to improve patient safety. Now, let's move to the next page, the last page. In the final page, we will continue discussion on Table 5, dangerous abbreviations, symbols, and dose designations, which highlights common prescribing errors and they recommend safer alternatives. Understanding these unsafe abbreviations is essential for reducing medication errors and improving patient safety. The first abbreviation, as I mentioned before, is U for unit. This abbreviation can easily be mistaken for the number 0 or the number 4 or even CC, potentially resulting in serious dosing errors. Therefore, the safest practice is to write the word unit in full. Similarly, IU, which stands for International Unit, may be misread as IV for intravenous or as the number 10. To prevent confusion, always write International Unit or simply unit as appropriate. Another important recommendation is to avoid abbreviating drug names. Many drugs abbreviations resemble one another. For example, MS may refer to morphine sulfate, while MgSO4 refers to magnesium sulfate. Such confusion can lead to administration of the wrong medication, so drug names should always be written in full. The abbreviation QD for every day and QOD for every other day are also unsafe. These abbreviations are frequently confused with each other or misread as QID, meaning 4 times daily. To eliminate ambiguity, prescriptions should instead use the words daily and every other day. The abbreviation OD, intended to mean once daily, can also be interpreted as a right eye for the Latin oculus dexter. For this reason, write daily rather than OD. Likewise, the ophthalmic abbreviations OS, OD, and OU representing the left eye, right eye, and both eye may easily be confused. It is much safer to write left eye right eye, or both eyes in full. The abbreviation DC is another common source of error. It may mean discharge, but it is often interpreted as a discontinue. Since these meanings are very different, the intended actions should be written explicitly, such as discharge or discontinue. The simple cc, meaning cubic centimeters, may be mistaken for the abbreviation of U for units. The preferred terminology is ml or milliliter. The abbreviation UG for microgram or can be mistaken for mg, resulting in a 1,000-fold overdose. To improve readability, prescriptions should use mcg instead. The symbol at, meaning at, may be misread as the number 2 or 5. Therefore, the word at should always be written out. The mathematical symbols greater than and less than should always be avoided in prescriptions because they may be mistaken for letter 7 or L or confused with one another instead. Write greater than, more than, less than, or lower than. Finally, Table 5 emphasizes proper decimal notation. A trailing zero such as x0 milligram is dangerous because the decimal point may be overlooked, leading to a 10-fold overdose. Therefore, never use trailing zero. Simply write x milligram. Conversely, a lack of a leading zero such as 0.x milligram increases the risk that the decimal point will be missed, producing a 10-fold dosing error. Always place a leading zero before a decimal value, writing 0.x milligrams, for example. In summary, Table 5 reinforced that many medication errors arise from unclear abbreviation, symbols, and dose expressions. Writing prescriptions clearly, avoiding dangerous abbreviations, and following a standardized terminology are simply but highly effective strategies for improving medication safety and protecting patients. Thank you for attending the lectures in this series. If you're new to the channel, don't forget to like and subscribe. See you in the next lectures.